Greetings, everyone. Thanks for finding me again. And if you found me for the first time, I just wanted to say thank you. This is actually episode number 4. So if you've just found me, I've got 3 other super short episodes. They're getting a little longer each time, I guess, ahead of this. So find those 2 and then bookmark those. And, you can find me on Apple Podcasts, Spotify, YouTube, all the usual places. And I try to make all the podcasts video, because I have a lot of graphics, and I think that actually helps for some of the stuff that we talk about. So yeah, look for me on all those places, and welcome. Today, as promised, we're talking about the thrilling world of anticoagulation. And again, this topic is for everyone. It's not for doctors, dentists. It's for patients. It's for your family. It's for your friend. I think it's something that's so prevalent that people should know how to manage these cases in the dental office and things like that. But I feel like there's so many questions that I get, and I'm going to get into a lot of questions at the end that people sent me already on this topic. And a lot of these are actual dentists, writing me and asking me these questions. Yeah, there's a lot of confusion still, even with all the studies over the years and, about how to manage people on blood thinners, anticoagulants, whatever you want to call them, safely in a dental setting. And so I'm going to try to clear some of that up and just kind of show you what I've been doing and then what's worked well for me in practice in 17 years. And so let's get into it. All right, so let's quickly just get into this right away. We're going to be talking about anticoagulation and how I manage these patients on blood thinners. And I'm not going to get into all the specifics of what type of blood thinner, but just real basic. Everyone knows warfarin or Coumadin. It's an old one. It's been around forever. A lot of people are still on it. It's the one that you have to get your blood levels checked for your INR to see what level you're at. And generally that you want a level of INR of 2 to 3 or even higher than 3, depending on what you're being treated for. If it's a blood clot, arrhythmia like AFib, something like that, history of stroke, and so forth. Patients are still on it. They got to check their INR. And that's the thing with Coumadin. The INR varies, right? So it can change daily. So generally what I do with patients on Coumadin or warfarin is we get an INR check the day before or the morning of the procedure. Just because it fluctuates daily, you want it within 24 hours. And that's worked pretty well in my opinion. And we'll get into some of the questions on what INR is good and stuff at the very end. People have asked these questions, and I'll tell you what I've been doing as well on all that. Anticoagulants like warfarin, and then there's the newer ones, the direct-acting thrombin inhibitors, factor Xa inhibitors, and so forth, like Pradaxa, Eliquis, Lixiana, Xarelto, and so forth. You don't need to technically get a lab to see where they're at, but they are blood thinners. They do have a shorter half-life than warfarin, and some of them you take twice a day. Some once a day, it depends. But yeah, we'll get into all that as well, how to manage that. And they're all pretty much managed the same way. And people are on Plavix, clopidogrel, or, and so forth, on aspirin. And simple question, I'm going to answer this right away. Do I ever take patients off blood thinners for routine dental procedures, oral surgery, extractions, biopsies, anything? The answer is no, I do not. We just manage any risk of bleeding locally because that's still safer than taking someone off blood thinners and increasing their risk of thromboembolism or stroke and so forth, or MI. I do not take patients off blood thinners. I haven't been doing that in 17 years, and it's been great. Patients are healthier. You don't have to increase their risk of these events. So what do I do? Locally, how do we manage the bleeding on these patients if we're not taking them off blood thinners? So there have been lots of studies. I have been using tranexamic acid. We used to send them to compound pharmacies, and we still do, so they can get it made ahead of time. And I'll throw up a list of what we give to patients, and we give them generally a list of how to use the rinse. We have on our paper, we actually give each patient that needs this a list of local pharmacies that can make it for them. Again, you can't take this to CVS or something. You have to take it to a compounding pharmacy to make this for you. Generally, it's like $60. It could be $100 for the bottle. Keep it in the fridge; it lasts longer. But yeah, it's topical. It's good for any cut, and they generally make up 4.8% solution or 5% solution in the compounding pharmacies. And the patients bring this rinse with them to the extraction appointment. We use it during the surgery, so we'll put some on some collagen, put it in the extraction site, suture it, over sew it with a resorbable suture on top as a hemostatic dressing. And they can use it at home if they have bleeding. And this is our post-op instructions. And one thing I do want to say on these instructions real quick is you see here it says, in the instructions, it says rinse with it, which you can do. And there have been studies on rinsing with it. But what I tell patients when they call, if I'm on call and they're saying I'm still bleeding and so forth, I find that patients don't put enough pressure when they're biting down on whether it's a tea bag or gauze or something with the rinse on it to stop the bleeding in their mouth. And so they think they're biting on it. It's hard to tell. It hurts, So I literally tell every patient, you have to fold the gauze, fold it again, put the rinse on it, squeeze some of the extra rinse out, put it exactly on top of the bleeding, and hold it down with your finger for 20 minutes with good pressure. Don't peek. Keep it there for 20 minutes and then slowly take it off. And that works pretty much most of the time because they're really not biting on it enough. So if you get these calls at night, you really have to tell them to hold it down, with their hand, or have someone help them do that if they're not able to. So how do I mix this stuff? So we buy these vials now in the office, and there is a dental code for this. So hemostatic dressing code D7922. That's a code we use for basically, on these patients if we're going to place a hemostatic dressing. And what is that? You can put some rinse on some collagen or put the collagen in the site to help occlude and form a blood clot. And so that's a code that you can use to, actually bill for this procedure because you are having to buy this. I'll show you here is this vial here that I'm going to put up on the screen is tranexamic acid. We get this from Henry Schein, but you can get it at a lot of suppliers, a lot of dental suppliers and so forth. This comes as a 1,000 milligram per 10 cc vial, and and it's basically a 10% solution. So what that really is 100 milligrams per 1 cc. That's too concentrated to use. So what you need to do is take this vial, dilute it with 10 milligrams of saline. So you get another, saline vial, and these are less expensive than this drug. Dilute it. So mix this 10 cc's with 10 cc's of saline, and then bammo, you have a 5% solution that you can use topically in the office. And so that's what we can do. And so we'll mix that in the office if we need it. It's pretty quick. Another way to do this, and it's a little less expensive for you guys if you're ordering this, is you can get a pill, basically. The problem with the pill is it's a 650 milligram tablet you can buy. You have to wait for it to dissolve in the water. So sometimes if you really need it quickly because someone's bleeding, having to wait for something to dissolve for 2 to 5 minutes is not the best thing. So that's the only thing about the pill. You can still use them if it's not emergent or anything like that. I don't think that's unreasonable, and I think they're a little less expensive than getting these vials. And so that's an option too. But if you need it quickly, it's going to take a little time to dissolve that tablet. So that's basically that. And you can put the 650 milligram tablet in 20 cc's of saline and dissolve that. So again, the hemostatic dressing code is D7922. So that's how that works. Real quickly, this is not a lecture. Tranexamic acid, the studies have been around for a long time. This study is from 1993, and this was in the OO, Oral Surgery, Oral Medicine, Oral Path Journal. And again, what they found, it was a double-blind randomized study, and they found that what they're saying exactly here, let me just show you, I can read this for you. We conclude that the anticoagulant treatment does not need to be withdrawn before oral surgery. And again, that was a study from 1993. And so there have been many studies since then, and people still have questions on how to manage this stuff, So I don't know where all the confusion comes from, but it's there. So the other thing is sometimes, patients are on other things. They're on a blood thinner, but they're on a few other things like garlic, ginseng, things like that. Those have been found to increase, antiplatelet activity as well. So just so you know, there's certain things like garlic, ginkgo, and ginseng that also are technically kind of like blood thinners too. So that can also potentiate any problems and so forth. Here's something I want to stress. If you don't get anything out of this, just a couple stories. Sometimes I have patients that see me, they get referred for a tooth extraction, and they think they're going to get it done that day or whatever they're thinking. And they come in, they say, hey, I've already stopped my warfarin. I'm like, well, did your doctor tell you to stop it? No, I just knew I was coming in, so I stopped it. When did you stop it? Like last week. All right. So why is this a big deal? So they kind of just stop it on their own sometimes. They just assume that they need to stop it, for any sort of surgical procedure, right? So now they're in your office and you're the doctor and they tell you this information. And what you need to be thinking in your head is, well, how long have you been off of this? And first of all, and also, why were you on it? Or risk of blood clots, atrial fibrillation, things like that. So that's a red flag. Whenever someone says, hey, they just took themselves off of it on their own, I'm like, how many days off of it have you been? If it's close to 7 or if it's getting close to 7, there have been studies now that show if you've been off your anticoagulation for 7 days or more, there is a statistically significant chance you're going to have a thromboembolic event, heart attack, stroke, and so forth as well. So that's a big deal. So if that's the case, I say, hey, you need to talk to your physician and you need to likely get back on that. Because if it's past that 7-day marker, that's a big deal. And this is a study just showing that basically as well. So just so you're aware, because they're going to tell you this information and you're the doctor, right? So you have to take that information and make the best possible decisions for these people, because sometimes they just assume, yeah, I need to stop it. And that's not true. So yeah, their risk of CVA and MI go up. This is a study in the journal Blood, right? So how I treat anticoagulated patients undergoing an elective procedure or surgery. And basically what they found is, interruption of warfarin in patients with arterial indications, especially in immediate post-op period, gives them a higher risk of stroke. And so, yeah, that's been found, right? So again, don't stop it. So let's get into some of these questions now. Some of this stuff is, interesting. So I'll just start with these ones here. So this one says, how to manage if you cut an artery or vein? So we're talking about something different now. This isn't technically a blood thinning question, although you could cut someone's artery and they're on warfarin. That would even be worse probably, right? So again, like I said before, pressure, holding a tea bag or whatever you're doing at home stops most bleeding. And the same is true in surgery. So the first thing you would do is pressure, however you can get it, right? So direct pressure on the bleeding, whether it's your finger, a gauze, bone wax. And I have videos on this on my other account showing how to use bone wax for bleeding inside a tooth socket. So all that works, and that's what you should try first, okay? Worst case scenario, you're a dentist. They're in your office. They're bleeding from an arterial bleed from, a deep tooth that you try to take out. Pressure. And sometimes you got to hold it there yourself and maybe even call EMS and get them to a center, if you can't manage it locally. And because if you take your finger off and it's still bleeding, then that's a problem. So whatever works to stop that acute bleeding. So that's a different type of question. So here's a question. Is discontinuation of oral anticoagulation also needed for mobile teeth? Again, they're asking me, do I need to stop this anticoagulation? And again, the answer is no. Don't stop it. Don't stop it for anything. So again, people are still asking the same questions, right? Antiplatelet versus anticoagulants management, for minor oral surgery. Again, this person's asking the same kind of question. Again, I just don't stop it, right? So antiplatelets basically prevent platelets from clumping, right? And they prevent clots from forming, versus anticoagulants which basically slow the clotting cascade and decrease your fibrin and so forth. So, and this person's asking, where do I get the Tranexamic rinse from? Like I said before, we get ours through Shine, Henry Shine, and there's plenty of dental suppliers and other suppliers that can have this for you as well. About the cost of it, the actual cost of it, if you get a vial, 10 vials per box, comes out to about $14.20 per vial of actual costs for the trans rinse alone. Add that to a vial of saline that you're going to buy to mix it with. So you're going to be mixing 10 cc's of the trans rinse with the 10 cc's of saline to get your 5% solution. So you add those two together. There's a syringe involved to mix them together. There's someone that you're paying, probably, or you, to mix them. So there's a little bit of cost with all that. So I think a generalized thing is, like, if you're charging for this, if you just want to charge cost, like $20, $21, whatever you want to mark it up, but that's basically kind of the cost of it, the real-time cost of it. Obviously, you need a license and stuff to order this stuff, so there's cost with that. But again, it's not a ton of money, and it's something that's very useful to have in the office for bleeding. This person's asking here is, do you give this IV or, again, we're talking about a topical solution. You can give Tranexamic rinse IV, but I would not do it, and I don't recommend anyone do it unless they have training in it. It's pretty safe, but it's something that you shouldn't just do on your own. I would use it still as a topical, in the office. This person's asking how to use the pills from directly in the socket to create hemostasis. So they're talking about those tranexamic acid tablets. Again, you need to dilute that. It's 650 milligrams diluted in 20 cc's of saline and make a rinse, make a solution basically, and use that solution. Don't put the pill in the socket. So that's that one. And how do we use the tablet form in the clinic? Again, like I said, it's going to take 2 to 5 minutes to dissolve that tablet in some saline or water. So there's a little bit of time with that when you're using the pill, although it's a little bit less expensive than the vials. And this person's asking, do you ask patients to stop blood thinners? Again, never. So you see how these questions come up. There's so many of them that are the same. Asking, when do we stop it? Blah, blah, blah. So yeah, I don't stop it. What's the normal recommended criteria for dosage and how do you give it and what to avoid? Again, like I said, so you can just mix those two 10 cc vials together and make a 5% solution in your office. And there's a dental code for that, like I said, together. So yeah, those are some questions that I got on this. And there's another set here. This one says, is it possible to do a surgical extraction when the patient is on a blood thinner and has hypertension? I mean, yeah, of course it is. Yeah, a lot of these patients do have hypertension and they're on a blood thinner for maybe arrhythmia or something else, right? So there's multiple comorbidities there. It's definitely safe. What meds do you need to check? How do we manage patients on direct oral anticoagulants and patients on heparin? I mean, heparin is IV, so I doubt you're managing heparin on your outpatients in your clinics. But again, the only labs you really need to check are with warfarin, and that's the INR. The other ones, there's really no labs to check. Patients on anticoagulant came to the ER with active bleeding after 24 hours from extraction. How do you manage that? So they're talking about maybe they extracted a tooth and then their patient had to go to the ER, or they sent them to the ER because they didn't know how to manage it in their office. So again, this is a good way. Like I said, using that rinse is super helpful if you use it correctly. Put it in the socket, put it on some gel foam, put it on some collagen or something like that. That's super helpful to manage these cases. What is your protocol for doing full arch implants on elderly patients with blood thinners? So sometimes, I stage the extractions. I don't just take out 15 teeth at once, and it sounds rough, but yeah, patients on blood thinners sometimes for various reasons, depending on how sick they are with other things, sometimes I'll take out a group of teeth at once, see how they heal, and then do the next teeth, and then finally do the rest. And so you don't always have to do it in one visit, is what I'm trying to say. And just you have to gauge each patient, separately with that and what makes the most sense for them. Yeah, so patients on anticoagulants, the active bleeding, we did that one. How do you order it? So yeah, like I said, Henry Schein is where I get mine from. So you can go on there, you'll see a box of 10 of these things for a certain price, and you can break it down how much each vial costs, about $14.20. I want to know your protocol. What is your INR cutoff, my man? So I would say generally 3.0 INR and less, I feel fine removing teeth in the office, and again, it's not just the number, it's what other, comorbidities does this person have. But generally I feel pretty comfortable with an INR of 3 or less for something like that. Tranexamic acid injection versus a tablet. Again, we got into that already, the pros and cons of both. Do you dilute it? How do you apply it? Blah, blah, blah. We've already definitely got into that. How do you use it in injection form? You can just inject it you dilute it into your solution and you can inject it through the IV, but I do not recommend you do that. Use it topically. Any advice for the surgery inclined general practitioner using rinse? Basically everything I've said, just use it. Use it on every patient that has a blood thinner, and don't stop their blood thinner. And generally you should be in pretty good shape if you use it the right way. Do you give it via IV or soak it in gauze? Again, I use it topically. Put it in the gauze, hold pressure, direct pressure is pretty much going to stop most things. What is your INR limit for implant wisdom teeth surgery? Again, like I said, about 3.0 or less. I feel pretty comfortable with that. When do you have to bridge with heparin? Again, this is a question generally most dentists don't have to deal with because of the newer acting antiplatelet agents. Most patients aren't on heparin when they stop their Coumadin because we're not even stopping their Coumadin, right? So we're not doing that stuff. How to manage any post-op bleeding or complications like liver clots. I do have videos on this on my Dr. Wahan account. Go check it out. But how do you manage bleeding locally, right? So you can manage bleeding pretty successfully in the office. Yeah, it's annoying. They come in, they might have been bleeding a little bit for sure, but that can still be managed locally. Inject them, oversew it, put some collagen in there, use the rinse and so forth, and make sure they're not bleeding before they leave your office is also helpful, right? Don't just send them out the door. Let them sit in the chair for about 15-20 minutes or more just to make sure that they're good. How do you use it? Possible complications and what to look for, contraindications. Again, I have them use it. They get their rinse at the pharmacy. They'll put it in the fridge. I think it lasts longer. And they can use it on any cut. I just tell them, yeah, keep it in your fridge. You can use it on any cut. It's a topical. And so it does help. And yeah, so this saved my ass a lot of times. That's great. It saved my ass too. That's awesome. What procedures will or won't do on patients with blood thinners and so forth? I'm not exactly understanding this. You can do most things on patients with blood thinners in our line of work, and like I said, I don't stop them, and so I just manage them locally. So, yeah, I got into a lot of these questions, and you can tell like there's a theme here with a lot of this. So there's still confusion on how to manage these cases. So if you have any questions about it, definitely hit me up, and if you want any other things discussed on how I manage things, oral surgery wise, dental stuff, medical stuff, anything like that, just give me a message. And thank you for listening. Thank you. Later.